for asking me to speak. I'm from Canada, you can hear from my accent, and I moved here, and my first job was in Whangarei, and I actually broke the New Zealand law my first night on call. Maybe this shouldn't be on YouTube, but I was looking after a pregnant woman who came in around 20 weeks with her water had broken early, and she went quickly on to get infection and sepsis and was quite sick, and so having just come out of my college exams, I knew the medical thing to do was to start oxytocin and the pregnancy, and she delivered the baby in the middle of the night. And I came in the next day, and my boss, Ian Page, told me that I had broken the law, and I was horrified. And I think the reason it didn't even occur to me to ask if there was a law, because in Canada there is no law about abortion, and that's been the case since the 70s. So my mentor and someone I learned from and looked up to was Dr. Henry Morgentaler, who was a very instrumental person in having abortion laws come out of the system in Canada. So I then had to become a certifying consultant and learn about the law here, so that wouldn't happen again. But then I was thrilled to see in 2017 when Jacinda Ardern campaigned on many things, but one of them was abortion law reform. And as you all know, she was elected, and there was a lot of advocacy through all rands, through probably lots of people in this room. And in 2020, on the 24th of March, the government passed new legislation. It went completely under the radar, because if you remember March 2020, 2 days later, the whole country was put into level 4 lockdown. So for better or for worse, it just became the new law. And we all had to pivot very quickly, both to level 4 lockdown and to the new law, to put into place services that could accommodate both the strict lockdown rules and the new law. So I'll just read you the new law, at least the first sentence of it. It says, a qualified health practitioner may provide abortion services to a woman not more than 20 weeks pregnant. That's the whole law, and that applies to 99% of people getting abortions in New Zealand. So there's a lot of key pieces there. There is some legal restrictions around women over 20 weeks pregnant, and that's a conversation, a whole other talk. But basically, when it talks about a qualified health practitioner, that really broadens the definition of who can provide abortion services. It used to be primarily obstetrician and gynecologists like myself, or GPs with a special interest in women's health, but it broadens it to nurses and midwives and potentially pharmacists and community workers. It also just means that I can provide abortion care as healthcare, the same way I provide contraception and hysteroscopy and anything else that I provide in my day-to-day practice. So I'm active on Twitter, and one of the big hashtags is abortion is healthcare. And that's just exactly how it feels right now to us and obviously to women. So for a woman who finds herself with an unintended pregnancy that she doesn't want, her journey is you Google it, and the first couple of sites that will come up, the first one that's come up always is abortion.org.nz, and there's some people in this room who've been involved with Ishtar, who has supported that website, and basically it's an independent source of information about how to get an abortion depending on where you live, and information around pregnancy options and the differences between medical and surgical procedures and everything you wanted to know. But more recently, the top site is the Ministry of Health website, and now that it's healthcare, it's come out of the Ministry of Justice and moved into the Ministry of Health. So they were also on the back foot, because it's not like anything else. With legislation, it changes from one day to the next. So the next day, suddenly, the Ministry of Health was in charge, and they didn't have guidelines or experts, or, it was all sitting previously with Justice. So I was involved on the executive, and still am, of APGANS, which is the abortion provider group. And we quickly, grassroots, the services, the providers just started putting stuff together right away. But basically now women can find the Ministry of Health website, and it has all the similar information where to find your closest abortion provider. And then the other change from the previous law is that you used to have to be referred by your own doctor, And although we tried to massage the definition of own doctor, basically you can now self-refer. So I would say probably about half of women are self-referring now. You just ring up the closest service and you make your appointment like you're making a hairdresser appointment. And the other half are being referred in by their own doctor. So it's lovely that it's now accessible much more easily. And then just to, again, that whole thing about not having two certified consultants that had to decide if you qualified or the abortion was justified. Now I don't have to do I don't have to prove that she's mentally unwell or physically unwell or there's any issues. It's just a healthcare service, and you know, our model of shared decision making applies here as well. So you listen to their story and you hear, you know, over, I don't know how many years I've been doing this now, but you just hear such interesting stories. It's this real privilege where every single woman in front of you is different, and you really get a sense of the vast breadth of reasons why people need this care, and they get the care that they need, and so that's a shared decision-making process. So Felicity asked me to discuss whether I felt that it had improved women's access, and we don't yet have great research on it, but I can tell you that the Ministry of Health annual report has been published for 2 years now. It used to be done by the Abortion Supervisory Committee. The first important thing is that the abortion rate has not changed, so a lot of the antis were like, well, if you make it more accessible, you'll have more abortions. That's not been the case, but what we have seen shift is how early in the pregnancy people have their abortion services. So that shift has gotten a lot earlier. So if you imagine taking out needing to go to your own doctor and pay for that visit, and maybe that doctor refers you, but maybe they don't. And so you can imagine taking out all that time of getting to that before you get to the service. And then, so that's the self-referral, the fact that it's just on Google, all the information's right there. So we've seen a lot more women having an abortion at under 9 weeks, and you know that the 9-week mark is the important time in a pregnancy because it gives you the ability to have a medical procedure rather than a surgical procedure. So New Zealand in the last year has gotten to about 50% of early abortions are being done medically, so now we're matching what's been seen in Europe. But one of the research projects I have on the go is I've now gotten 3 years worth of data from the ministry of all 14,000 abortions per year from the year before abortion law reform and the year after, and we're going to actually, instead of just showing those graphs, we're actually going to look at that by ethnicity and by region around the country, because we suspect that there's probably still a lot of inequities, even though it generally looks good, we expect to see some inequities still. The other thing that's changed this year is that the government has publicly funded an 0800 national telehealth abortion line for early medical abortion. So that also adds to, we'll see next year what the impact of that is. Certainly the abortion services have seen their numbers going down a little bit over the last couple of months. It just started in November. But now you basically call the 0800 number, you get access to counseling, you can have an early medical abortion through that where they do the assessment, make sure you're eligible, they post you the medications and you take them at home, and then you do a urine pregnancy test a few weeks later to check that the pregnancy has ended, and all of that is done via telehealth. So there were really good models of that published out of the UK during the pandemic showing that that was safe and effective, so that's what's been launched here, and that's not been evaluated yet, but we'll see in a year's time what that looks like. So one of the unintended consequences of all of this telehealth and early medical abortion is that you have an opportunity when you see them in person to give them good contraception. So although they all have access to contraception counseling and they can get a prescription for the pill, for example, that's also done electronically with the pharmacy nowadays. What they can't get is a gel in their arm or an intrauterine device placed at the time. And we know that people who get those sort of long-acting contraceptives are less likely to have another abortion in the next 12 months. So that's a great New Zealand study that was published several years back. So that is something we are seeing less of, and it will be interesting to see if we see more unintended pregnancies with the increase in EMA. Felicity, you mentioned the guidelines. So we never had guidelines. We had standards from the ASC, and so with that being disbanded, there was a gap, and I tendered alongside another group to create a clinical guideline for abortion care, and that was published in 2021. So we were able to look at all the evidence. We didn't have to worry about laws of taking medications on premises, supervised in licensed premises. Now you could give women medication to take home. So we were able to just do an evidence-based review and talk about best practice and not be limited and restricted by the law. And then there were some things that came out that were not really clinical guidance, but they were not quite standard, so those went into policies. So that's the same thing. It's just regular healthcare. So it now sits in something called Aotearoa, the Health and Disability Services Standard. It was published in 2022 alongside all the fertility standards and the maternity standards. So now it's just one document. It's just health, like all these other areas of healthcare. And finally, you mentioned teaching. So it's really exciting at phase 2, which is year 4 and 5. We created a new teaching session for the whole class, talking about the abortion legislation changes and all of the medical stuff underlying and all the social and cultural stuff underlying abortion care. All year 5 medical students in ONG during their 5-week attachment do get to an abortion clinic at some point. They don't have to, they can opt out, but we encourage them to go along and observe the counseling and get to meet and hear the lives of some of these women that are requesting abortion care. We think that's really important. If 1 in 4 women have an abortion in their lifetime, then as medical students, even if they never set foot in a clinic again, at least they've had that experience of what that looks like. In postgrad, it's trickier. So the medical council has a curriculum for PGY 1 and 2 for the house officers, and Prof. Stone and I wrote a recommendation back when they created that curriculum 10 years ago, because very little women's health was in there, and we advocated for things like abortion care, but it didn't get included. So now I volunteer to give a lecture on abortion care, and they tell me that it's not part of the curriculum, so I can't teach it, because it's like you're only going to study something that's going to be on the exam, right? So I'm actually not even allowed. So what I've done is I've created early pregnancy lecture, which includes early pregnancy care for an ongoing pregnancy, and we talk about vaccines and healthy weight gain, etc. But then I also do a piece on abortion, so I've snuck it in, which is good. But then the problem is that I know the same thing has happened at the RANSCOG level, where in fact abortion care is not on the curriculum even of an ONG registrar in their training. So when I want to do lectures for the registrars on their Friday afternoon teaching, where the list of curriculum is like this long, that's also not on it. So again, I sort of sneak it in with other lectures on miscarriage and ectopic pregnancy, etc. So they are getting taught it, but they don't. I've never once seen a registrar in XMD for the 8 years that I've been working there. So that's something we are working on. We've got a really the Vice President, Jill Gibson, is very passionate about this, and we are working on getting an advanced training module so somebody can come and do 6 months on abortion and sexual and reproductive health. And then in terms of providers, so the primary goal of objective of APGANS is to offer education and training for providers. So now that health practitioners are a much broader group, our membership has increased month over month with new GPs and new nurses and new midwives coming along to our education days and becoming members, and we share education and research and articles and just have some peer discussions as well, what it feels like to be a provider, because even though it's been decriminalized, you well know that there is still stigma, and it's something that's quite difficult for us. Some of us don't tell our families, our friends. I don't go advertising that I do this kind of work, so it's definitely improved a lot. I'm now willing to do things in the media, for example, about abortion, whereas before before the law changed, I really wasn't comfortable. So that's been a huge change. But it's still, and then the other part is the emotional part of hearing these stories day in, day out, but just, they're all every woman has at